continuing education series. You have a really good presentation in store for you tonight. A little bit of housekeeping. All guests, please keep your devices on mute. We encourage you to ask questions for tonight's speaker, Dr. Marc Gimbel. Do this through the Q&A box, and the questions will be held to the end of the presentation. In order to receive the CDE credit, please remember to complete the evaluation at the end of the presentation. The link to complete that evaluation will be posted on our CDE page at zoufalhealth.org/CDE. That's zoufalhealth.org/CDE. The evaluation will remain open for 1 week after the course. Once a survey is closed, CDE credits will be issued to participants. You will also find links to register for some upcoming courses, the next one of which you'll have some information later is to occur on October 24th. We also display our past courses here. After the course ends, you'll find a survey below Dr. Gimbel's name on our CDE webpage. And again, this evaluation will be open for 1 week, and your certificate will be sent to you the following 2 to 3 weeks. So I'd like to turn it over now to my colleague, Shade Cronin, Senior Vice President for External Affairs. She'll share a couple of announcements, and we'll be introducing our guest speaker. Enjoy.
Thank you, Dr. Rappaport, and good evening, everyone. I'm Shade Cronin, the Senior VP of External Affairs here at Zoufal, and we're glad to have you with us tonight. I just wanted to share a little bit of background about Zoufal for those of you that may not know us. Zoufal is a federally qualified health center. We are headquartered in Dover, New Jersey. We were started as a small volunteer free clinic by Dr. Bob Zoufal and his wife Kay. You'll see their photograph there, actually in front of our dental building in Dover. Zoufal has 12 clinical sites plus 2 mobile units that cover 7 counties in Northwest and Central New Jersey. We take care of about 45,000 low-income and underserved patients every year. We are very grateful to our sponsor for our continuing education course, Delta Dental. Delta has been a longtime partner of Zoufal's and has supported us on many ventures over the years, including our Delta Dental mobile unit, which you'll see a photograph there on the top with the ribbon cutting of that vehicle. They support our Smiles for Our Heroes event, which is an event where we provide low or no cost dental services to veterans. And we have just begun planning for our next Smiles for Our Heroes event that will be next spring. And Delta has also been a wonderful supporter of our new dental department in our West Orange building. We have a current site in West Orange, but we're getting ready for a ribbon cutting for our new expanded site that will open in November. So we hope that some of you will come and visit us at that location. I wanted to share a couple of other initiatives in oral health that Zoufal is working on right now. In addition to the continuing dental education courses that Dr. Rappaport spoke about, and we hope that you will join us for some upcoming courses, we also have a community dental health coordinator program. We graduated our first class of this program last fall, and we are getting ready to graduate our second class in a couple of weeks. And we will be starting to recruit for a new class of dental health community dental health coordinators in early January. We would love to have you get further involved with Zoufal. We always welcome any charitable tax-deductible donations to the Zoufal Health Foundation, which supports the health center and the work of the health center. The link to donate is here. I would also call your attention to our upcoming benefit, which is on Wednesday, October 11th. We would love to have you join us there. We've just put the link in the chat for that. It is www.zoufalhealthfoundation.org/benefit. We'd love to have you join us for that event. We are raising money for a new mobile medical unit and honoring our past president and CEO, Eva Turbiner. We would also welcome any of you that are interested to join us as a volunteer provider for our Smiles for Our Heroes event. Again, that will be coming up next spring. We are working on a date. It will be either May or June of 2024, and you can contact Dr. Mayetta. Her email is here on the screen if you're interested. There is a credentialing process to go through, but we would love to have you join us as a volunteer provider, providing those no-cost dental services to veterans. Tonight, we welcome Dr. Marc Gimbel as our speaker. We are thrilled to have Dr. Gimbel back with us. Dr. Gimbel is a highly accomplished and esteemed figure in the dental community. He's renowned for his expertise in endodontics. He earned the prestigious title of Diplomate American Board of Endodontics in 2010, which reflects his exceptional skill and knowledge in the field. Currently serving as clinical assistant professor at the Rutgers School of Dental Medicine, Dr. Gimbel imparts his wealth of experience and knowledge to postgraduate students, shaping the future of endodontics through his teaching over the last 31 years. After earning a bachelor's degree in biology and chemistry from the State University of New York at Albany, he received his DMD from the University of Pennsylvania School of Dental Medicine and completed postgraduate education in the field of endodontics at the University of Medicine and Dentistry in New Jersey. Dr. Gimbel, we are thrilled to have you here with us tonight, and I will turn it over to you. I think we are having just another technical challenge tonight, so give us just a moment and we'll have Dr. Gimbel on the screen to begin the session in just a second. Welcome, Dr. Gimbel.
Hi.
All right,
Nice.
I will turn it over to you. Thanks for being with us tonight.
Okay, great. Let's go back up to the. There we go. There we go. Okay. Let me take care of a couple of housekeeping issues myself. First of all, I want to thank Delta Dental again for having me, and specifically to Dr. Ron Deblinger for introducing me to Zoufal so many years ago. I've had a great relationship with them. I've volunteered at their Dover site. I think this is the second webinar I've done with them. One was last year. This is this year. And I think the last year's lecture will tie in quite nicely into this year's lecture. I was just talking with Dr. Rappaport. Last year's lecture was about endodontics and the judicial system, and the takeaway lesson from that was know your limitations. I think we're going to start off this lecture by seeing how far we can take the limitations of endodontics using new technology. And, you know, all the cases that I'm going to present to you are either done by myself or the doctors in the office. And if it's done by any of my students, I'm going to give them credit as we go through the lecture. But I want you to see what really high quality endodontics is all about from a specialty perspective today in 2023. So I'm also going to have my trusted, dear, best assistant, Dr. Parth Kalathia, here in case we run into any technical difficulties, and he's going to be helping me out throughout the lecture just to make sure everything runs smoothly. FYI, most of these cases that I'm going to show you are done with Zeiss microscopes and the Carestream CBCTs and Sonendo's GentleWave. We're going to bring in some cases done by lasers and other things, but I will tell you as we're moving through the lecture what was done with what. So first, let's take a visit to the past. Parth, you want to bring me to the... No, yes. This is an example of, you know, a warning that I think I gave out at the last lecture, where sometimes when you get involved with a case, you really don't know what you're getting involved with because you're not looking at it in 3 dimensions. The upper left slide, can you see my cursor as I'm moving it around? Shows a broken rotary file in a tooth that has a 90-degree curve. And it's never a good look for you as a practitioner to start a case and not really understand what you're walking into before a problem happens. So this case was sent to us with a broken file straight at the 90-degree curvature, and we were able to use the GentleWave to get around and get out that broken file at the curvature. And this is the end result using, softened gutta percha. So this is kind of how I started doing endodontics. Believe it or not, these bead sterilizers or salt sterilizers were what we used to put our files in between working on teeth. We used to sterilize the files by putting them inside this little oven. We had Bunsen burners to heat up our instruments when we were burning down the gutta percha, and we would culture the bacteria inside of the canals. We used electrophoresis. We had all sorts of barbaric devices back in the 80s and the 90s. This is all unheard of. None of the dental students now that are in the postgraduate program where I teach or in the GPR program at Zoufal probably have never seen these things, but this is how I started. So we're gonna have a couple different philosophic statements as I go through the lecture, and Parth is going to do his best to keep me on time. We have a lot of material to cover, so if Parth butts in, that means I have to speed it up. Spending money on experiences, material things are nice, but experiences are the things that will make you truly happy. When I got involved with GentleWave and Son Endo, I really didn't do it for myself. I did not. I had younger doctors that were 30 or more years younger than me. They wanted to try this technology. We looked at it, and I said, you know what? Research and development, R&D, sometimes works out great. Sometimes you invest in a product or a machine and it winds up on the shelf. But I never look back. Whenever you put money into R&D, research and development, sometimes it's going to take you to a new level. And so it did indeed with Son Endo's GentleWave. So I want you to understand, you are almost always looking at endodontics from a two-dimensional perspective. I am always looking at it from a three-dimensional perspective. So when you look at these teeth from a two-dimensional perspective, they're all going to look like one canal. But the reality is, if you treat it as one canal, the case will fail. Root canal therapy works by what you take out of the tooth. So you have to get rid of all the bacteria and all the organic tissue in order for root canal therapy to work. It does not matter if it looks like a great fill on the radiograph if you haven't found all the canals, and I'll show you a couple of slides exactly like that. So you have to understand when you're going into a tooth, for instance, mandibular anterior teeth are known to have two canals. Mandibular first premolars are 30% of the time are going to have one canal that splits into two. You have to understand the root canal anatomy of the tooth you are working on. So here is a patient. I tried to sprinkle this lecture with a lot of cases that we can look at and ooh and ah about, but again, all these cases are our own cases. Here's a patient that shows up with severe pain on the upper left quad, root canal completed by another local endodontist 3 years ago. First of all, from an endodontist, the worst person I want referrals from is from another endodontist. I don't want to clean up the mess created by another specialist. I don't mind cleaning up messes created by our general dentist colleagues or other specialists, but it's not a good look for me to be working on other endodontist cases, especially when they're done a week ago or a month ago. So in this case, the mesial buccal root is failing. And we all know that there is likely additional anatomy here. 95% of maxillary first molars are going to microscopically have another canal, microscopically. Okay, so we bring this patient in. The first thing we do is we want to see three-dimensionally what's going on. And it looks like there is a periapical area. This is the coronal view of the mesiobuccal root, which has only been filled incompletely, and the rest of the anatomy has been left unaddressed. We put in the calcium hydroxide, and sometimes we're going to take a calcium hydroxide scan in the middle of treatment, and we're looking good. We follow it up with, another appointment, and we're going to use the sonendo, and we're going to, I'll explain to you later how that works. And we're seeing that not only did we get an MB2 coming off this canal, but we also located an MB3 over here. And we were able to get our sealer into the MB3. This is the post-op CBCT, and then we brought the patient back. This is the periapical that we'll send back to the referral, and then we bring them back for recall to check for healing. Look at our healing with all that interesting anatomy, MB1, MB2, MB3. It's a whole different world when you're looking at these teeth, understanding that the anatomy is what's guiding the treatment, not your two-dimensional imagery and your just looking at getting into one of the canals. Root canal therapy will not work unless you have removed all the bacteria from all of the canals and all of the organic matter. And here we go. Here is the recall on that same case with the healing. This is a very new case that both Dr. Berry, Craig Berry, and myself worked on maybe a month ago. And we will often work hand in hand. Dr. Kreitman, myself, and Berry will each take different steps. I may be better at working down calcified canals. Dr. Berry and Dr. Kreitman might be better at using the sonendo, and we tap into each other. So this was a calcified case with a pin that I think the first visit I spent, and I just got down the palatal and the distal buccal canals. And then the second visit, I was only able to get down MB1. And I called upon Dr. Berry to see if he can get out the GentleWave and help me out with MB2. And as soon as he ran the GentleWave through it, he was able to start packing off the canals, and we were able to see the sealer coming up the MB2 canal as we were packing off the tooth. So we were able to use the GentleWave to get through some of the calcification, some of the obstructions, so we can get a, and if you look really closely, I don't know if you can see it, but you see the streak of sealer on MB2 going all the way down over here. So that was a case from probably a month or two ago. This is a case going on right now. I haven't even finished this case. A woman came in. I think I did a lower molar root canal for her about a year ago on tooth number 30. Everything went great. Her dentist put on a bridge from 28 to 30 6 months later, and she came back with heat sensitivity. I know she's not getting heat sensitivity from 30. I wound up testing 28. Now take a look at the anatomy on 28. This is a coronal view. You see the anastomosis running between the buccal and the lingual canals. What you don't see is that these canals are 35 millimeters long. The longest files I have are 31 millimeters long. So I was able to clean this tooth out. I was able to cut off the plastic ends of the hand files, and they still weren't long enough. So we have to order veterinary files. If you order veterinary endodontic files, they will come as long as 45 millimeters long. So I have to order 45 millimeter long files. That's the first time in my career after I left the University of Pennsylvania, because I remember I did do one case at the veterinary school there on a police dog. But here I am using that trick to work with this necrotic tooth number 28. So I need to kind of switch your mindset a little bit away from the way you were trained. You know, we were all trained at different times. Dr. Rappaport, myself, you, the people in the audience, all were trained in the last, you know, so many decades. And I'm sure the training that you got in the 1990s and the 2000s and 2010s are different maybe than I got when I was introduced into endo in the 80s, or Dr. Rappaport. So we have to kind of always be willing to reinvent ourselves and look at the technology that is available to myself. My mentor, Louis Lin, who unfortunately passed away just a few years back, gave me this advice that you have to reinvent yourself every 5 years, otherwise you stay stagnant. So since I came out of school 35 years ago, I've had to reinvent myself 7 times. So that's the advice for you. If you got out of school in 2017, or 2018, it's time to reinvent yourself, because you're out of school 5 years and technology has changed. So keep your mind open to growing. Here is, I know you've all heard of this. Hess is a gentleman that originally published this study 105 years ago, where he took extracted teeth and he injected them with dye and with wax, and then dissected them, and he was able to see all of the complex anatomy inside of these teeth that back at the time was pretty widely dismissed, until more recently, in the last 10, 15, 20 years, people have now started to think, hey, how could I be thinking that I'm going to be cleaning out all of the bacteria in these canals when we have 3 canals, anastomoses, webs in all these canals? You're not getting it unless you're truly looking at what's happening. This is a case where the patient was sent to us with a failing MB2, and we were not able to get entrance into the MB2 from the occlusal. And we tried as best as we could, but we knew there was an MB2 there from the CBCT. So we ran the GentleWave, I think twice. We let it run its normal 7 to 8 millimeter cycle, and then we let it run again. And look how we picked up all of that anatomy, not from the occlusal aspect, but we picked it up through the anastomoses. And you could see it here, how we were able to clean out all the bacteria and fill it with cement. So that was a case where we could not get in, but yet we were able to clean it out, and it was successful. Here's an example, again, things you're not seeing, that when we look at these teeth extracted, we can see so many, these are called portals of exit, or POEs, that are like a delta formation. When you clean out a tooth like this, and you're just using standard instrumentation, you may not be able to get 1, 2, 3, 4, 5 portals of exit because they're not completely clean. Here's an example of a case we did not long ago where we were able to use the GentleWave, and we were able to get into 1, 2, 3 portals of exit on the palatal canal, 2 MBs, and a distal buccal. And notice the shaping of these canals. They're very thin. The shaping has changed over time from when I was originally in dentals. When I was originally in dental school, I think Tronstad was my undergraduate my undergraduate endo instructor, we were told we had to open canals, anterior teeth up to an 80. That would never fly today. But what is one of the most frustrating parts of endodontics? I'm going to throw some acronyms at you, things that we use in endodontics. PTSD, which stands for post-traumatic stress disorder. In endodontics, we refer to that as persistent tapping sensitivity disorder. When patients come in and they continually tap their teeth and they wonder why, you know, they're still sensitive because they're tapping their teeth all day long. Well, some of that is because they're tapping their teeth all day long, and some of it's because of things we don't see. So here's a case that I'm in the middle of right now, where a patient presented with a history of trauma and I can't move this, right? No, a history of trauma with apical lesions on 23, 24, 25, and 26. Looks like your standard inflammatory lesion. Everything about it reeks of just normal everyday endo. The only problem is when I pulp tested these teeth on 23, 24, 25, and 26, they all tested vital. So I went back and I tested them again underneath the crown margins with the analytic technology of the Cybron tester, and I tested them again from the other side, and they all test vital. So this is not making sense. How are we getting periapical lesions on 23, 24, 25, 26, and these teeth are still testing vital? So we have to send it out for the scan to be interpreted, and it comes back as all these other things are possible, from odontogenic keratocyst, multiple myeloma. The case has to be biopsied. Also, teeth number 24 and 25 are obliterated with calcification, so this would have to be handled surgically. 23 and 26 can be handled conventionally. But the point is, we can't just go ahead and treat these cases just because they have a lesion. They're all testing vital. Just throwing that at you. Here's one of those cases with PTSD where, look at the upper left-hand slide. We see a very high-quality root canal with a post and a crown, and we now are starting to see periapical breakdown. Why? Why are we getting it? Years ago, we might have come at this with an apical surgery, but today we would opt maybe to retreat this case, take off the crown, get out the post, and try a session with Sun Endo or GentleWave. That's a machine that has been available probably since 2014, 2015, and we were able to treat the case and pick up additional anatomy here and anastomosis here, and then get healing just by retreating the case and using GentleWave. I don't think we would have gotten this type of success had we not had the advantage of using the Sun Endo or the GentleWave machine. We've spent 100 years trying to figure this out. When you use rotary or hand instrumentation, the files are not touching every aspect of every canal. So in this slide, the instruments, the red lines are showing you where you are touching the canals, and the green is showing untouched. So if we can find a way to attach the green, you know, this is an MB2, crazy anatomy, that will help us increase our success rate. Just bear in mind, there is no treatment in the world, medical or dental, that has 100% success rate. Endodontics by itself has a very high success rate. In the hands of an endodontist, we have a 96% chance of success. By using additional technology, you can increase that success by a few more points, maybe a point or two or three, but you're never going to have 100%. The endo activator, this is, I think, the second generation that we're using now. Some people might refer to this as a poor man's GentleWave, right, Parth?
Yes.
But it has its applications. Not every tooth is amenable to the GentleWave. So I have been using endo activators since they came out, and I think this new version is much, much stronger than their original version. This is put out by Dentsply Sirona, and I think we just got this. And these disposable tips go into the canals, and you use them for several minutes in each canal to activate the solution that you're using, whether it's sodium hypochlorite or something else. And it gets into all the dentinal tubules, and it helps disinfect the root canal system. It does not deliver any new irrigant to the canal, but facilitates the penetration and the renewal of irrigant in the canal. The whole point in irrigation is the more irrigant you use, the more we're cleaning out all the debris and bacteria inside of the tooth. Endovac is something that came out years ago. I remember I bought it, the first version of it, and it's a system where you place the chemicals and the suction very far down in the root canal system. They came out with another version. I think they pulled this off the market shortly after they manufactured it, but it helped increase the irrigation and the suction inside to provide a lot more fluid. Ultrasonic activation, we also use this, a nice adjunct to root canal therapy, again, to activate the chemicals as they're sitting inside your tooth to destroy more bacteria and to dissolve more organic matter. The laser has been out for a while as well, gaining a lot more popularity. There's a number of different brands that are out. A new laser came out maybe 2 or 3 years ago by Edge Pro to help with the bacterial removal and getting into the complex cases. And we're going to talk about that briefly during this lecture as well. Here's a case that was presented to me by my colleague, Dr. Joe Luzo, who was one of my students about 13 years ago. And he got involved with GentleWave maybe a few years after me, a year or two after me. And this was a case that he used his laser with. The root canal retreatment on the premolar here was failing, and he was able to remove the post and get out the root canal filling material. And look at all those portals of exit he was able to get when he filled the canal using his laser. And I think he's using the Edge Pro. These are these from Pete Parente or from Joe?
Dr. Lewis.
These are from Dr. Luzo as well. He's using the Edge Pro, and the laser is placed inside the canals, and he's able to activate it and pick up all of this anatomy here. In this case, he was not able to get any further down on the distal, but the laser was able to clean out this distal curvature, and he was able to pack cement. And in this case, he was hardly able to get down the MB2, and he was able to put the laser in there, and that was able to help him get his cement and get his filling down as far as possible. Dr. Parente just sent me this case, and he's using, I think, a Fontana, or I think he has 2 different types of lasers in Lancaster, Pennsylvania. He was my resident about 10 years ago, and these are the type of cases we see here in an endo office. You know, a distal canal that's splitting. He could only get to this point, but the laser was able to get him all the way down here. And on the mesial, he was able to get down and have patency here. So in endodontics, it's all about what you remove from the tooth. You could fill this tooth, any tooth, with sterile bird droppings. If you've removed everything and disinfected it, it doesn't matter what you put in it as long as it has a tight coronal seal. So we're concerned with disinfection. That's the biggest part of endodontics. Instrumentation, we're going to talk about doing cases with no instrumentation these days, which is something that was heresy years ago, and obturation. You know, there's all different sorts of obturation techniques we could talk about, but some obturation techniques make it easy to hide a poorly cleaned out case. Remember, if you have not cleaned the case out properly, it doesn't matter what you're putting in the case, it's going to fail. But if you make it look good, it's still going to fail. Can we do better? Look, I'm sure the things we're talking about today in 2023, we're going to improve on them by 2033. You know, endodontics remained stagnant from like the 60s and the 70s until 2000, and then we kind of rapidly changed everything. So we always have to be looking for the next thing, the next piece of research. This is Henry Ford. If we asked people what they really wanted back in the early 1900s, they would have said faster horses. We don't need faster horses. We need faster transportation. So Sonendo, who manufactures the GentleWave machine, this is their G3, right? So they're already on to the next version, G4. Uses a procedural handpiece, which is right here, which is disposable. And I'll show you how it gets used. And this is kind of like the cart. When you're in the airplane and they're serving you drinks, that's about the size of this cart. You can move it around from room to room, or you can keep it stationary. So the way that Sonendo works involves fluid dynamics. We're going to get into this a little bit more, chemistry and sound. And this here is the old part. This is the old three-piece unit. They've changed the way the unit works, and I'll talk about that too. Fluid dynamics, chemistry, there you go. To create an environment in which the body can heal itself. That's the goal. So this is a picture of the way the old three-piece system used to work. The sealing cap sits on top of a platform. Basically, you are creating with, what would you call the
Soundbar.
No. What would you call the platform? What are we making it out of?
Sound seal.
Sound seal.
Flowable rubber dam material.
It's flowable rubber dam material. We create a platform and we put the sealing cap, which fits a tight seal on top of it. It starts to create pressure and steam. It runs through a cycle of water and injects that into the tooth. The fluids come into the tooth. We start to develop cavitation or cavitation bubble cloud. The bubbles collapse, shock wave production goes in and out of the tooth into all the nooks and crannies. We are using broad spectrum acoustic energy. The plate is reflecting the chemicals, which are the same chemicals you're using inside root canal, which is sodium hypochlorite and EDTA and sterile saline, but the chemicals are degassed. There are no bubbles in the chemicals, which allows it to do this. And we create negative pressure. This is not, we're not forcing chemicals into the tooth. We're forcing them in and they're being deflected back right away. So we're kind of sucking everything out of the tooth. And then all of it gets exhausted into the sealing cap and back into the machine. So we're going through a lot of fluid on each and every case. And the cycle takes around 6 to 8 minutes, depending on which level you have it at. Right, shockwave, vortex, what does this look like? So here is a quick little video to show you on the left what it's like when you're using needle irrigation to what we're doing with the GentleWave. And the GentleWave, this is your platform and your handpiece is up here. And pay attention to what's happening inside, inside of the canal system. It doesn't happen immediately, but it happens by the end of the cycle. And there we go. All clean. So tissue dissolution. The tissue dissolution rate using the GentleWave system was more than 7 times greater with 3% sodium hypochlorite than the second fastest device used. So we're getting a lot more tissue dissolution. Disinfection of the dentinal tubules. Sodium hypochlorite penetration in the dentinal tubules using the GentleWave system was at a significantly higher rate, 4.5 times compared to active ultrasonic irrigation. Here's some SEN photographs showing you how clean the root canal system looks at the end of the cycle under very high electron microscopy. Root canal cleaning. We all know that the cleaner the case is, the more success we're going to have. This is what we're dealing with in dealing with root canal systems. There's oftentimes a fin coming off of a canal, and there's oftentimes interesting anatomy like a C-shaped canal. When you're cleaning just the MB and the ML and the distal, what do you think's hanging out in here? I remember when I was doing my endodontic program, they would say C-shaped canal anatomies have a 15% higher failure rate. Why? Because our instruments are not designed to clean out in the isthmus. Let's take a look at some histological samples. When you're cleaning out, this is no instrumentation here. This is instrumentation and regular irrigation like you and I are doing normally with hand instruments or rotary instruments. Look at what we're leaving behind. And this is what's happening with the GentleWave after instrumentation. So the GentleWave system removes 97% of tissue debris when compared to conventional rotary instrumentation and irrigation, which removes 66% of tissue debris. It's not an exact science. It's going to add a couple of points to your success rate. This Parth is an example of the new G4. Is that correct?
Yes.
So this is the new product that they have been selling probably this year. It is better because what did they remove from the old machine?
They made some changes about the mechanism, about degassing mechanism.
Right. So the old
yeah.
machine G4 has multiple degassers, and this one only has one. So less items to break. So the volume of fluids per average molar, we're putting 160 to 200 cc's of sodium hypochlorite at 3% and 40 to 80 cc's of EDTA. How much of sterile saline are we using as well?
It's after we finish the GentleWave cycle, we irrigate the canal system with the saline. So I would say 10 to 15 cc.
But in between the sodium hypochlorite and the EDTA, the machine is flushing the canals with 30 seconds in between the first and second cycle, and then it flushes it again.
Yes.
So there are 4 different fluids that are going through the tooth. The first is water. The second, sodium hypochlorite. Then the
third,
water. Then the fourth, EDTA to remove the smear layer, and then water again. And then we are manually using chilled saline as well. So there's a lot of fluid going through every single case. Right, and the machine is doing this for you. Another advantage of the new machine versus the old machine is the old machine, you'd have to change the chemicals after 2 or 3 cases, usually 2 cases. This will go as far as 7 to 8 cases, so less maintenance on a daily basis. Here is another video for you. I want you to pay attention to this lateral canal and this lateral canal on this lower premolar. This video is going to run about another 45 seconds.
This is with the activator.
This is the endodontic activator that they're using. It's going to leave over some of the debris. And now, right. And here, now we see the GentleWave being activated. Watch what's happening in these lateral canals and to the apical extent here and here. Look at the fluid dynamics of what's happening here. And this case is very similar, there you go, to the introductory slide to this lecture where I showed you that anterior maxillary incisor, and you saw all these lateral canals coming off of it. This is exactly what's happening. And there we go. So, but in order to get there, you can't just hook up the machine to the tooth. You have to create a stage for success. And that involves this platform right here. And this is the matrix. I'll show you a little bit more. So in order for this to work, we need good isolation with a rubber dam, bone dry, no decay inside of the tooth and no temporary fillings, excellent hemostasis. We're going to cure that sound seal or that flowable rubber dam material in layers. You need a quick acting ultraviolet light. We had to buy all new ultraviolet lights in order to use this system. So I think we had to buy
5 second or 3 second.
Right, it has to cure the material very quickly. And again, you have to have clamps for every single tooth and appropriate saliva control. Dr. Calafia here invented a clamp called the Party Time. I wonder, did you call it Party Time because Parth, P-A-R-T-Y? Or anyway, this clamp has an extended bow, which allows you to place the procedural instrument on the tooth with a lot more access to the coronal part of the tooth. So a lot of GentleWave users have found these Party Time clamps on the internet that makes it easier to use the GentleWave system. Again, if you do not remove all the caries, the force of the sonic and ultrasonic energy being generated in this machine is going to clean out that decay, and you're going to have chemicals flowing everywhere. And initially, when you're starting your learning curve to how to use this machine, you learn that you have to take the fillings out yourself to check for recurrent decay. If, let's say, someone else said, oh, I cleaned it out and I put in Key-Tac, and they didn't really clean it out, the GentleWave is going to just blow right through that, and the machine's not going to work. This is the flowable rubber dam material, and you're creating basically a ledge on top of the tooth, and we can use bonding agents, like the same agents you use when you place composites, and there are different applicator tips, and we can cure it in multiple stages, but we have to have a tight seal. And oftentimes before I even do anything, I will apply alcohol to the external portion of the tooth or the crown to just make sure there is no saliva there, and it actually helps a lot with the bonding. Here we go. You see the ultraviolet light. This is the matrix that gets placed on top of the flow. You have to put a ton of the sound seal on top of here. It goes right on top of the tooth. This is the dentist applying the sound seal to the matrix. It gets put right on top of the access chamber. That's what it looks like. And then you put your procedural instrument right on top of this. There is a little bit of refinement that sometimes has to be done here in case any of the material is blocking the way. You have to be able to see all of your canals when looking through this hole with your mirror. And then the procedural instrument is placed on top, And this is the clean flow, correct? Because we have,
This is APM,
This is-
anterior.
okay. Seal is the deal. This is what the old G3 screen looks like. It's a touch screen. You had choices to use the molar PI, the anterior PI, or the clean flow. Most of the time we're using clean flow. These procedural instruments are a bit more powerful than this one is. And then you select whether you're doing a necrotic case, a vital case, a retreatment case, or you just need extended time. Like that case I showed you earlier where we were not able to get into the MB2, we needed more time. So the machine is set up for it. Remember, these handpieces can only be used once. So after you use it, it gets thrown away.
Mark,
Yes.
we're going to need some time for questioning.
Okay.
Almost done. We'll finish with this after this procedure demonstration.
Okay.
Maybe 3-4 minutes.
Give us a few more minutes and then we'll start with the questions.
Okay.
Okay. The machine provides a leakage test at the very beginning using water. So if you have not created a proper seal, it's going to tell you right off the bat. And even if it leaks, it's just leaking water. You use a suction under the rubber dam. You can have a suction running on top of the rubber dam. And the machine itself is a suction. So you have 3 suctions running when you're using this machine. This is Dr. Calathia, and he is holding the procedural instrument on the patient's tooth for a solid 7 to 8 minutes. So while he's doing that, the doctor is, filling out the chart or standing at the side of the room or doing something else. So there is not a waste of downtime. Okay. Here's an example. You're going to tell me when to stop, right?
Okay. Yeah.
Here's an example of an anterior case with massive bone loss. I guess the previous dentist had a procedural mishap, and we used the GentleWave on this machine. And lo and behold, here we are a year later. Look at that massive amount of bone that we have regenerated in just 12 months. Okay, stop at this point. All right, how many questions do you want to take, Dr. Rappaport?
The first question would be, are assistants allowed to hold the GentleWave handpiece for the entire cycle?
Yes, this instrument is an irrigation device. And in the state of New Jersey, as just as your assistants are allowed to hold the suction or the air water syringe, they are allowed to hold the device for you for the entire cycle. Of course, we have to train them first.
How long does it take to do the whole GentleWave cycle?
So in the beginning, I would say it would take us 20 minutes to do the platform and to run the cycle. But now that everyone is so much equipped and prepared to do it, I'd say anywhere between 5 and 10 minutes, the whole thing is done. Depending on a necrotic case is going to run faster than, let's say, a retreatment case, that's going to take more time.
And apparently the last question is, how much does the GentleWave cost versus the laser cost per case?
So the prices on all these things are very varied. Lasers, if you buy the most expensive laser, it could be well over $100,000. The newer lasers that are coming out that are specifically designed just for endo are running around $35,000. The Sonendo machines initial purchase is it around 65?
60 to 65.
60 to 65,000 for the purchase. And then you have to buy not the sodium hypochlorite, but the degassed EDTA from them. And you have to buy the procedural instruments from them. And you have to buy the warranty after your initial warranty runs out.
Yes.
So the cost is differing for each modality. Does that help?
The next question are these molars instrumented at all?
So I haven't gotten to that part of the lecture, but all of the cases that I have shown you, except for the one that we were not able to get into the MB2, have been instrumented by hand and with rotary. So this case, I think Parth is going to bring you back to at the beginning of our lecture. No, it's before that. This case right here, the MB1 was instrumented, but MB2 was not. So we're going to talk about cases as I continue on with the lecture, cases that we don't instrument at all. You know, as there are some premolars and some anteriors that are well open. We don't use any instrumentation besides maybe a size 10 file for patency. That's it. How much more do we have?
Maybe a couple of slides, but I don't think
Dr.
so. We have
Rappaport,
time.
we're going to.
Yes.
I think we have one last question.
Okay.
On the retreatment cases, removal of gutta percha is required first.
Yes.
GentleWave does not.
GentleWave will not take out gutta percha. You have to manually do that with solvents or with hand instruments or with rotary instruments. You have to get out the gutta percha. GentleWave will not take that out. As well as GentleWave will not take out the calcium hydroxide. You have to take that out as well.
Wow. Thank you. Thank you, Dr. Gimbel. It was a pleasure having you part of the CDE series. Hope to hear from you again.
Absolutely. I'd love to.
Absolutely. So thanks again. Our
My
next
pleasure.
course will take place on October 24th. The information should be on your screen. So you can visit the Zoufal Health Organization /CDE for registration. And of course, that's the site to get your CDE credits as well. So, and a reminder, you must take the survey to get credit for Dr. Gimbel's course. And at that www.zoufalhealth.org/CDE. And thank you again for your attention and have a
Pleasure.
great evening.
Thank
What
you.
could have